This concise video log on using HIV-ASSIST to guide ART switch in a patient with chronic kidney disease was pre-recorded by Dr. Maunank Shah. Clinical Care Options provided this CME activity, and CME credit can be earned by accessing this activity on the Clinical Care Options website. This educational program was supported by grants from Gilead Sciences, Theratechnologies, and ViiV Healthcare. Dr. Shah is an associate professor in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine in Baltimore. This vlog is part of a comprehensive educational program on using HIV-ASSIST as an educational resource for selecting ART in patients with HIV. You can obtain downloadable slides on the Clinical Care Options website, as well as gain CME, CE, or CPE credit by viewing this vlog.
Hi, everyone. My name is Maunank Shah from the Johns Hopkins School of Medicine, and I'd like to share an interesting case with you all. This was a patient that we saw in clinic in the last year when she transferred care to our institution. She was a 55-year-old woman initially diagnosed with HIV back in 2012. She had a number of comorbidities, including type 2 diabetes and schizophrenia, and for a few years, she was not on antiretroviral therapy until these came under better control. And eventually, she was placed on risperidone and had better control of her schizophrenia. And ultimately, it was more engaged with care and initiated treatment with rilpivirine, TDF, and FTC in 2014. At the time of transfer, we reviewed her records, and they were notable for the fact that at the time of diagnosis, her pretreatment HIV RNA was 75,000, and a genotype at baseline showed wild-type virus with no drug resistance mutations. As I mentioned, she had a couple of comorbidities and was on risperidone as well as on insulin, and her diabetes was never under terrific control with an A1C of about 12 over the span of several years. However, at the time of transfer, she was in fact doing quite well from the standpoint of HIV with an HIV RNA that was undetectable on rilpivirine, TDF, and FTC, and her schizophrenia remained in pretty good control. Her diabetes had started to improve. Her A1C had dropped down to 8.5 after both long-acting and mealtime insulin was instituted. But over those ensuing years, she did develop worsening hypertension and had to be initiated on a handful of antihypertensive medications, namely lisinopril and amlodipine. And her kidney function had progressively declined, such that at the time of transfer, her GFR was under 60, it was about 55. And in the year prior to transfer, she had actually gone to see renal and had a renal biopsy, which suggested that she had diabetic nephropathy. So given those things, at the time of transfer, we thought this was a pretty good time to reassess her HIV regimen and ask whether we should be considering any medication changes. And what I'd like to walk you through now is the way in which the HIV-ASSIST tool could be used to help inform ART switches in a person with HIV who is virologically suppressed. Here you see the relatively straightforward user input screen on the HIV-ASSIST website. And it asks for a number of key considerations and characteristics to be entered. Importantly, in this situation, the current regimen was entered as rilpivirine, TDF, and FTC as a single tablet regimen, and her viral load was entered as being suppressed. We included the fact that she had chronic kidney disease with a GFR between 30 and 60, and indicated her preference for avoiding intramuscular medications, which was noted on the top right of this screen. The tool also allows you to enter co-medications and assesses for drug interactions, and so the co-medications were entered as well. For those that have not used the tool before, I'm just going to walk you through the output. Before I show you the main results screen, when you get to the results, here you'll see a snapshot of what appears at the top of the screen. There'll be a blue bar with instructions that can be clicked on to provide a little bit more explanation for those that are newer to the tool. Now, we do have a separate module that can walk you through the way the tool works and how it calculates the HIV-ASSIST score and ranks regimens. But in brief, the tool evaluates almost every permutation of HIV antiretroviral therapy combination, and it ranks it based on the considerations of whether there's likely to be able to achieve viral efficacy and tolerability. And it presents those results in a color-coded fashion such that lower scores are preferred and higher scores mean that there's either less certainty in the evidence or that there are co-medications or comorbidities that might make a regimen less preferred. So here I show you the results from this particular patient's case scenario. Given that the patient was already virologically suppressed, what's notable is that there's quite a number of different drug permutations that were evaluated and considered likely to be effective at being able to preserve and maintain viral suppression. But the differences in these scores are attributable to the fact that different regimens have either drug interactions or considerations with regard to the comorbidities, and in this case, the chronic kidney disease, that push some of these regimens further down. The tool tries to provide information to help the clinician make a regimen selection. So rather than providing just a single recommended regimen, what it's trying to do is, in a transparent way, give you, the clinician, the needed information to be able to make an informed decision. Right from this particular snapshot, you can see that on the main page, the tool tries to summarize the number of active drugs in each regimen, as well as the number of pills and dosing frequency. But there's quite a bit of other information that's also embedded. For example, one might wonder, as we did in this case, why the patient's current regimen of rilpivirine, TDF, and FTC, which they've been stably taking and suppressed on, is showing up as less preferred than some of the alternatives. So you can get quite a bit more information by just clicking on the actual regimen. When you actually do that, 3 additional pieces of information become available. And what I'm showing you here is the middle tab, which is the dosing information. So the first thing to note is that the tool pulls from the DHHS guidelines, as well as the FDA package inserts, and includes any needed dosing adjustments. And in this patient's case, what you'll notice is that while they've been taking rilpivirine, TDF, FTC as a single tablet combination regimen, given that the GFR has reduced it to less than 60, the recommendations are that this pill should in fact be broken up, and there is a dosing adjustment, and that's explained at the top of this dosing information tab. But there's additional information as to how the regimen and the tool came up with the final weighted score, which made this regimen show up a little bit lower in the rank list. By clicking on the rationale tab, what you see is that this regimen started off at a priority score of 1.0. And that's because this regimen in this patient has been able to maintain viral suppression over a long period of time. So it starts off at a score of 1.0. The tool then sequentially goes through a number of different rules to adjust this score on the basis of the pill burden, any mutations, which in this case there were none, as well as any comorbidities or drug interactions. And in this patient's case, what you'll see is that this particular regimen gets a fairly sizable penalty to the HIV-ASSIST weighted score because it includes the drug TDF in a person with chronic renal disease with a GFR that is under 60. One can click on the additional information tab from the main HIV-ASSIST output screen and get yet more information about why this penalty was assessed. If you're wondering where this information comes from, essentially it has been largely summarized straight from the DHHS guidelines. So for example, by clicking on the additional information and comorbidities, you'll get a table that shows you the penalties that are being assessed for each particular drug with a little summary that is taken from the current guidelines. So for TDF, for example, one can look at the table in the guidelines on how to consider specific antiretrovirals in the presence of various other conditions, including chronic kidney disease. And the summary here is that in general, the guidelines say to avoid TDF because TDF has been associated with proximal renal tubulopathy. So that information is also summarized here, allowing you to quickly access relevant information from the guidelines right in one particular tool. So let's now take a moment to think a little bit about how one can switch antiretroviral therapy when there is the presence of comorbidities or toxicities. There are a number of reasons that are outlined in the current guidelines as reasonable reasons to switch antiretroviral therapy in a patient that is already virally suppressed. I'm not going to read all of those reasons here, but I'll just note that it is considered acceptable to consider a regimen switch for the purposes of enhancing tolerability or decreasing toxicity. And when it comes to renal disease, the HIV-MA guidance on antiretroviral therapy in patients with chronic kidney disease specifically suggests that one should consider discontinuing TDF when the GFR declines to lower than 60, and that's particularly true when there's evidence of proximal tubular dysfunction. This information is also summarized in the National HIV curriculum, and the language that is used in the curriculum is presented on this slide. And it notes that regardless of the cause, that one should think about discontinuing TDF in persons with HIV who experience a decline in GFR of more than 25% or to levels less than 60 milliliters per minute. So what should we be thinking about in terms of potential options if we want to avoid TDF in this particular patient? So on this slide, what you see is a summary of the different regimens that can be considered in terms of both within class switches as well as between class switches that have been studied in various clinical trials. Notably, there has been evidence to switch TDF to TAF with maintenance of virologic suppression. And there's also been evidence to switch NNRTI regimens to integrase inhibitors and other regimens as well. Importantly, there's now also increasingly evidence that one can make a switch from a 3-drug antiretroviral therapy regimen to a 2-drug regimen, and that this is considered appropriate in particular to manage toxicities, intolerance, or for patient preference. Some of the regimens that have been studied in particular are a switch to dolutegravir rilpivirine as well as dolutegravir and 3TC. Here I show a summary of a number of the different studies that have actually been published. And across the board, what you find is that there are a number of different within class and between class switches in which switching to an alternative regimen has been non-inferior to continuing the current regimen from the perspective of being able to maintain viral suppression. In particular, in the SWORD studies, individuals were switched from 3-drug antiretroviral therapy to a regimen of dolutegravir and rilpivirine, and there was demonstration of non-inferiority for being able to maintain viral load under 50. Similarly, in the TANGO study, a regimen switched from a 3-drug regimen to dolutegravir and lamivudine was able to maintain viral suppression even out to 96 weeks. This information is also available within the HIV-ASSIST tool. If one clicks on either one of the regimens from the output screen, what you find is an education sheet which summarizes a number of different key pieces of information, but within each of those education sheets is actually a table in which there is a summary of available evidence for using these particular regimens. And so you'll notice that in the dolutegravir 3TC education sheet, there is a summary of the TANGO study, and in the dolutegravir rilpivirine educational sheet, there's a short summary of the SWORD trials. So once again, this demonstrates the way in which the HIV-ASSIST tool can help provide easy access to relevant clinical trial information that is relevant to your patient right at the point of care. Coming back to the patient's case, here I show once again the output from the HIV-ASSIST tool after we had entered the relevant information. What you'll notice is that in particular, dolutegravir rilpivirine shows up as one of the potential options as a 2-drug regimen that could be considered. So on the screen, you'll see that dolutegravir 3TC has a slightly higher HIV-ASSIST weighted score and is subsequently a slightly lower rank than dolutegravir rilpivirine. If one clicks on that, the rationale for that is that at this GFR, this is a acceptable regimen, but if GFR was to continue to decline, that single tablet regimen would potentially have to be split up based on the current dosing recommendations for usage of that regimen in individuals with more advanced kidney disease. Other regimens, as you'll notice on the screen, including 3-drug regimens, are in fact considered acceptable, including regimens such as bictegravir, TAF, FTC, which would be a switch of the anchor drug from an NNRTI to an integrase inhibitor, for which there is clinical trial evidence. And in that particular regimen's case, it would be a switch from TDF to TAF, which has also been shown to be acceptable from the perspective of maintaining viral suppression. In this case, TAF has not been penalized to the same degree as TDF because TAF has less nephrotoxicity than TDF, though I'll note that there have been instances of TAF-associated nephrotoxicity as well. It's partially for those reasons that while those regimens still show up as being relatively preferred regimens, they show up slightly lower than the regimens that avoid TAF and TDF altogether. So in discussion with the patient and the team, a number of those different regimen switches were considered. And after talking with both the renal consult team as well as the patient, there was a preference to avoid tenofovir, both TDF and TAF altogether, in part just to avoid any confusion and complications if the diabetic nephropathy were to get any worse, and to avoid any considerations for other dosing adjustments or for concern that there could be additive toxicity in someone that already has underlying kidney disease. Both dolutegravir, rilpivirine, and dolutegravir 3TC were considered. And in this particular patient's case, because she had been on rilpivirine, TDF, FTC before, she had a bit of a preference for trying to preserve as much of her prior regimen that she already knew and felt she had been tolerating as possible. And the patient therefore preferred the option of going to dolutegravir and rilpivirine, which was the final regimen that was selected for this patient. So in summary, I think there's a growing body of evidence to suggest that 2-drug regimens are in fact effective in maintaining virologic control in persons with HIV that are virally suppressed. And improving tolerability or decreasing toxicity are among the reasons one might think about actually making a switch from a 3-drug ART regimen to a 2-drug regimen in the setting of viral suppression. I hope I've been able to demonstrate the way in which the HIV-ASSIST tool can help clinicians by bringing multiple different clinical resources together to inform ART selection all together in one convenient place. Some of the resources that are available are summaries of guidelines and primary literature. While we didn't discuss it extensively in this case, there is built-in drug interaction considerations, and the tool also brings in information from the Stanford Drug Resistance Database as well. So by pulling all that together, using the HIV-ASSIST tool can help guide ART selection. In this case, helped guide ART selection in a person who had comorbidities as well as other co-medications. Thanks for joining me today, and I hope you'll take the time to give HIV-ASSIST a try.